Hello, everyone. Good evening. Thank you for joining us. I know it's a very beautiful day in Northeast Ohio. So, for those of you who are joining us live, I appreciate your time. There are over 2,600 people registered for this. So, there's a lot of excitement surrounding this. So, let's have fun. My name is Pelham Bator, and you are joining the Ask the Experts virtual event on managing menopause. And just a little bit about me, I'm fellowship trained in women's health and a menopause specialist at Cleveland Clinic. And joining me are my fellow OBGYN specialists from Cleveland Clinic. And we are committed to providing you world-class care with our colleagues and helping you through your journey into perimenopause and menopause. So what we're going to do tonight, we're here to answer your questions, share our expertise, and provide clinical insights. We're going to talk about what to expect during each stage, perimenopause, menopause, postmenopause. How do these changes affect our skin, our hair, our weight, all of the stuff that we care about, how this impacts our mental health, how to find relief from the symptoms, and also how it impacts other things that we really care about. How do these hormone levels impact our libido and our sexual health? So our team is here. We're here to provide support and coordinated care. And in general, our team is not just about menopausal care. We do care that impacts all of women's lives, general gynecology, childbirth for my OBGYN colleagues, infertility, incontinence, gynecologic cancers, pelvic floor disorders, menopause, and much more. And some of the locations that we practice in is really throughout Northeast Ohio and beyond. So if you want to see us, we are honored to see you. We had a lot of interest around this. We had more than 500 questions submitted. So we looked through those questions in advance, tried to put them into categories and duplicates, and we are going to try to cover as much as we can. And we will send out an email after tonight's event that includes information about menopause and women's health related services. So before we jump in, two things. The first one is I'd like to just state that we are really talking about those individuals born with ovaries. So we're going to use the terms women, she, her, and this might not capture the full diversity of those experiencing menopausal symptoms. And we definitely need more research for the diverse group of peoples that experience menopause symptoms. So let me introduce, without further ado, my esteemed colleagues. And what I would like them to, well, I guess I'm supposed to introduce myself too. I've been at the Cleveland Clinic for 26 years. In July, it'll be 26 years, since 1998. I see patients at main campus. And my areas of focus is really menopause, what we call complex contraception for premenopausal hormones, sexual health, menstrual migraine, and osteoporosis. And what we would also like each panelist to answer is a question about, as a woman, what advice would you give a friend about discussing menopause with their clinician, their provider? And I'll start that conversation. I would say, please bring up your concerns, whether it's sexual health or menopause, but keep in mind that if you're there for your annual visit, and the doctor or the nurse practitioner says you need to come back in for a dedicated follow-up, please do that, because the typical wellness visit with your primary care or your OBGYN oftentimes doesn't give enough time to get into the complexities to give you the answers that you need. So that would be my biggest advice for taking charge of your care and navigating your care. So next on the panel, I'd like to introduce Dr. Talia Crawford. Dr. Crawford, do you want to tell us about yourself?
Hi, good evening, everyone. My name is Talia Crawford. I have been in practice for 8 years and with the Cleveland Clinic for 4 years. I see patients at main campus and the Beechwood Family Health Center. My areas of focus are vulvovaginal disorders, sexual dysfunction, and menopause care.
And then do you want to tell us, as a woman, what advice would you give a friend?
So as a woman, I would advise a friend to read reputable sources before going in to talk to her providers, such as visiting menopause.org. There are a lot of great patient resources on that website. And I would also say, don't be shy about bringing up sexual health concerns. That's a really important part of a menopausal transition.
And next, we have Dr. Erica Newland.
Hi, as Dr. Bator mentioned, I'm Dr. Erica Newland. I'm seeing patients primarily out of the Westlake office, and I do a full spectrum OBGYN care, seeing patients for pregnancy, post-pregnancy, birth control, everything under the sun as far as OBGYN. Similarly to Dr. Crawford, I see patients as well with vulvovaginal concerns, and thinking about what I would tell a friend going through menopause is really find a provider who's taking your concerns seriously, because a lot of times menopausal symptoms can really impact your life and shouldn't just be written off. And there are things that we can do to help, for sure.
Perfect. And last but not least, Dr. Jackie Zupancic. Do you want to tell us about yourself? Oh, you're muted. Dr. Zupancic, you're muted.
Great. Oh, I thought that NPR was going to handle that. I'm so sorry. Okay. I'm Jackie Zupancic. I'm a generalist OBGYN down in Akron. I've been practicing for 6 years. In addition to all the generalist OBGYN things that we do, like, GYN surgeries and obstetrical care, annual visits, well women, things like that. I do have a special area of focus in women's sexual health as well as in menopause. I've been practicing in downtown Akron. I also have offices in Greene and Fairlawn. So lovely offices down here. But my advice to a friend would just to be open about your menopausal symptoms. I don't think that menopausal education has gotten a very good foothold in this country. And a lot of what may seem not related to menopause often kind of falls within that category. And so be open with your provider. You may be surprised about the extent that menopause can impact your quality of life. And until we know what your concerns are, we may not be able to help you. So don't be hesitant to bring those up with your provider.
Perfect. So now that we've gotten to know our panel, it's time to answer your questions. So again, we received more than 500 amazing questions, so we're going to do the best we can. And so the first question, let me see, I have them all lined up here. This is for Dr. Newland. How do you know what stage of menopause you're in? Is it common for symptoms to come and go and intensify during different periods of time?
Yeah, so thinking about the stages of menopause, we kind of divide it in 3 different stages. So menopause we define as a year without periods. So we're kind of making that diagnosis in a retrospective diagnosis. Perimenopause is that time, usually when we're in our 40s, where our periods are starting to become a little more irregular. We might skip periods and then have a super heavy period afterwards. And that perimenopausal period can last 8-10 years sometimes. And that's often when women are starting to experience their symptoms. And then when we talk about postmenopause, that's the time after that year without a period. And it's very common for symptoms to come and go during that time period. And the way that we diagnose menopause is very much off of your periods. So sometimes I have a lot of patients coming in asking for labs to prove that they're in menopause. And sometimes for different patients, that may be the right thing for them. But often those labs don't tell us as much as what your periods are doing and what your symptoms are doing.
Yeah, very important point. In fact, sometimes the labs help force us towards the wrong diagnosis or make us have a mistake. So this next question is for Dr. Zupancic. How many years does the menopause typically last? You're muted.
To kind of interchange the word menopause and postmenopausal. And when you think about, I think when women think about menopause, they think about the symptoms primarily that are associated with it. So culturally, and just from, I think, social media, we think of menopause as hot flashes. Technically, once you have gone through menopause, that 12-month period of time, you are menopausal or postmenopausal for the rest of your life. So however long that will be. When we focus symptomatically on what seems to really bother us, especially as we make this transition over time, the average time that hot flashes tend to last for any woman is 7 years, which is a lot longer than most people think. Some of us are really lucky. We have an occasional unicorn that has absolutely no vasomotor symptoms like hot flashes or night sweats. Once in a while, we have women that have hot flashes and night sweats throughout their entire life, and only time will kind of tell where things go with that. Often we walk in our family members' footsteps. Talking about menopause may not be a conversation that is common with your older family members at this point in time, but sometimes what they've been through can be a gauge for what we should expect in ours as well.
And can you also comment about for example, if somebody is 45 and they're still having regular cycles and they're having symptoms, could that be then part of menopause or perimenopause?
So perimenopause, yes, absolutely. So perimenopause, I think, is this odd time where we're still having periods, but now we're also beginning to have symptoms of menopause as well. Everybody loves that a couple of years of their life. Typically, we'll see that transition can start to happen over a 5-year period. Once your periods become irregular, you can expect them to end in around 1 to 3 years. But while your periods are still regular, you may not see that end of your menstrual cycle for about 3 to 5 years.
And yeah, one thing to call out is that individuals of color sometimes have a lot worse symptoms and it lasts longer. So the average, she mentioned 7 years, and for individuals of color, it can be 10 years or beyond. So this next question is for Dr. Crawford. What are some premenopausal symptoms and what are some tips to manage these symptoms?
There are many symptoms that someone may experience during the perimenopausal and premenopausal phase of her life. Most commonly, women complain about hot flashes and night sweats, but also may experience brain fog, fatigue, mood changes, or worsening of existing mood disorders, weight gain, difficulty losing weight, changes in skin, hair, and nails sometimes, and then vulvovaginal symptoms such as dryness and other sexual dysfunction concerns, as well as joint pain and menstrual irregularities. So I'll go through some of the top 4 and some ways to help alleviate symptoms. For hot flashes and night sweats, cooling techniques might be helpful. So sleeping with a fan in your bedroom, dressing in layers, layering your bedding, and then lowering the room temperature can also help with some of the night sweats. Avoidance of alcohol, spicy foods, and also excess caffeine can help to limit hot flashes and night sweats. Exercising regularly and normalizing body weight, if that applies to you, can also be helpful. There's also some limited evidence that clinical hypnosis may be helpful for addressing hot flashes and night sweats. For brain fog, just stay engaged is the most important thing. Socialize, get out of the house, learn new skills, exercise regularly, ideally for 150 minutes per week, and then avoid smoking and excess alcohol consumption. Fatigue is also a common complaint that we hear. For fatigue, we would encourage you to optimize your sleep hygiene regimen, going to bed at the same time, and ideally waking up at the same time every day, and avoiding any kind of LED lighting devices prior to bed. And then eating healthy, hydrating, and also avoiding excess caffeine, especially later in the day. Mood changes may occur. It is important that if you have a pre-existing mood disorder, that you pay attention to worsening of your symptoms and have a low threshold for seeking care with your behavioral health professional if you feel like your anxiety or depression is worsening. Otherwise, increasing sleep and just making sure that you're getting 7 to 8 hours of sleep per night, exercising regularly, and then managing stress is critically important to help optimize mood.
Perfect. And just to highlight, I mean, estrogen interacts with all of our cells in our body, but doesn't mean we're all going to get all of those symptoms. There's no one universal menopause syndrome, and some people are lucky they go through it with very minimal symptoms, and other people get hit by a lot. So Dr. Crawford made a good point of like taking the top 4 and just trying to prioritize. And I do also want to just call out, even though we're not oftentimes checking a lot of FSH, estrogen type of hormone lab tests to make diagnoses, we'll oftentimes check a thyroid. If you're feeling tired, we want to make sure you've gone to your primary care doctor, you've had some basic blood counts done. If you're having a lot of brain fog, sometimes, vitamin B12. So just making sure that, because other medical conditions can actually be aggravated during this time. All right, next great question that we have is going to go to Dr. Zupancic, and that is menopause and weight gain. It's almost universal that people bring this up in the office with me. So what can be done to prevent it and stop it? How can we manage it?
Right. So I think what's tricky about menopausal weight gain is that a lot of it is normal and expected, but that also means it's very, very frustrating. We see that with decreasing estrogen and progesterone as we get closer to menopause, it really does impact our metabolism, and it can slow that metabolism. Particularly as we become menopausal, we lose muscle mass, which you'd think would make you lighter, but then what ends up happening is that muscle mass is then replaced with more like adipose or fatty tissue. And then when you are physically active, because you have less muscle mass, you're burning less calories. So it can be this kind of nasty feed forward cycle. We also know that in menopause, if we're having hot flashes and particularly night sweats, and we're not sleeping well at night, it's going to impact our energy the next day, and we're going to be less likely to want to or have the energy to do that physical activity. So what can we do to prevent this? What can we do to help along with that process? And a lot of this goes along with what we've been told kind of throughout our lives, like healthy eating practices and physical activity. That number will stabilize, certainly, but a lot of the things that worked for us well for our weight management when we were younger don't work as well as we get older, and we have to incorporate new practices. So when we think about healthy eating and exercise, we'll find that caloric intake and monitoring that is always going to be more helpful than exercise alone, and that you can undo a lot of progress with exercise by not monitoring your diet. A big dietary thing that we tend to recommend is the Mediterranean diet, which is very plant forward. It has low carbs and lean proteins associated with it. You can meet with a nutritionist to discuss your diet, or even consider a food diary to watch what you're eating over time. And then being physically active as well, certainly. So both cardio and strength training. A lot of women find that yoga and Pilates, especially for maintaining your flexibility as you age, is quite helpful for preventing or stabilizing that weight. If your BMI is greater than 30, or you're having more trouble than just what we consider average, there are obesity and weight management specialists within the Cleveland Clinic that we can connect you with as well. A lot of people in my office ask about whether or not hormone replacement therapy will help with weight gain. And unfortunately, the studies don't support that hormone replacement therapy has any effect on weight within the postmenopausal population.
Yeah, that's such an important part to highlight, because very large studies have looked at that. And in one study, hormone therapy users were 1 to 2 pounds heavier. And in the other study, they were about a pound lighter. So you can argue whether that really is related to the hormone therapy at all. It's, I think, a good point that you make, that shouldn't be the main motivator. But certainly if you're not sleeping, you're feeling tired, just like you said, that can help in that regard. All right. So for Dr. Crawford, what can be done to alleviate, manage night sweats and hot flashes? Do they ever go away?
So this is quite variable for everyone, but they can last 7 to 14 years. We did discuss earlier in the session some lifestyle modifications and behavioral modifications, dietary modifications that may help alleviate hot flashes and night sweats. So in answering this question, I'll focus primarily on medications. So two classes of medications that your women's healthcare professional may discuss with you. Hormone replacement therapy is the first. Hormone replacement therapy is still the gold standard for managing hot flashes and night sweats. For women with a uterus, estrogen and progesterone will be recommended. The progesterone portion is very important to protect the uterus from the effects of the estrogen. There are multiple formulations available for estrogen, including oral pills, tablets, transdermal patches, gels, a vaginal ring. For the progesterone, it may be in a combination patch with the estrogen, also an oral tablet, and sometimes the provider will recommend insertion of a progesterone intrauterine device. For women who have undergone hysterectomy or don't have a uterus, they can use estrogen replacement therapy only, without the progesterone component. For women that are not candidates for hormone replacement therapy or prefer alternatives, we do have several non-hormonal medications that we will recommend for treatment of hot flashes and night sweats specifically. Those include antidepressant medications and the drug classes of serotonin reuptake inhibitors and serotonin and norepinephrine reuptake inhibitors. Examples of these medications are paroxetine and Effexor. We also sometimes recommend gabapentin, which is a medication that is commonly used for chronic pain. And then oxybutynin, the brand name for that is ditropan. It's used for overactive bladder. The newest non-hormonal drug on the market is called Veoza. That medication was approved about a year ago. So it is important to discuss all these medication options with your provider and, discuss which one is the best fit for you. I will caution everyone about the use of compounded bioidentical hormone replacement therapies, such as hormone pellets and transdermal implants. These are not regulated by the FDA, so they are not recommended due to safety concerns surrounding that.
Yeah, I think that's important to highlight. We do see a lot of individuals coming in with pellets that sometimes really push them into very high doses of levels. I'm sure you've all seen that in your practices. And we've seen, uterine cancer from that or very bad symptoms. And once it's in, you can't remove it. That's the problem. So thank you for all. Something that people ask me about is clonidine. What are your thoughts on that?
So I think that has kind of fallen out of favor as one of the medications that would commonly be used to address hot flashes and night sweats. I think using the other four that I mentioned is more ideal.
Yeah, so clonidine was a blood pressure medicine that people used to use in the old days, but it's not recommended for high blood pressure nor for hot flashes. So even though I have select patients that do okay with it, it's definitely not a first line option. And the nice thing is the menopause.org website that we had also talked about, that's the North American Menopause Society that's been renamed as the Menopause Society. So every few years they do a detailed review of all the scientific literature of what works for hot flashes, what doesn't, what's not worth spending your money on or taking risks of side effects on, and they will list that out. And we also have that on our Cleveland Clinic website too, all the different prescriptions that have been shown to work better than placebo. Because the one thing I'd like to call out is placebo effect in both sexual health studies and menopause studies are actually quite high. Some studies it's 40 to 50%, which means that the powers of belief, if we gave you a tic tac and put it in a pretty bottle and sold a good story about it and maybe charged a lot to make it convincing, 40 to 50% of patients can get benefit. And as a menopausal woman myself, is that because we're all crazy? No, certainly not. But the powers of positive thinking we know has a therapeutic effect working on the hypothalamus. So I think that's where if you're using a medication, you want to use something that's shown to provide better benefit than just a tic tac, right? If you're going to pay money for it, you're going to have it go through your liver and your kidneys. And then I know you had previously mentioned, Dr. Crawford, the cognitive behavioral approaches and hypnotherapy. Do you have any more specific advice on any of that? I know it's hard to find somebody to refer for that.
Yeah, the clinical hypnosis, I don't unfortunately have a local referral for that. So that would be something that I would have to look into locally here in Cleveland. But multiple sessions are recommended if you are going to do clinical hypnosis. And of course, you would want to go to a provider that typically deals with menopausal symptoms and knows how to correctly manage that.
Yeah, it's interesting. I think that hypnosis ties in the whole concept of the powers of positive thinking and taking away negative thinking, because we know negative thinking makes hot flashes worse. I'm not gonna, get a hot flash if I'm vacationing with my family, but if I'm gonna go up to a podium and speak to 500 of my colleagues, that's probably when I'm gonna get my hot flash. So both negative energies and positive energies going to our brain can impact our experience. So we do have hypnotherapists within our functional medicine group. So I don't know how many there are, but that's actually pretty cool. And I've referred some patients. So when patients call our Women's Comprehensive Health and Research Center, I think in the follow-up materials, they'll have the phone numbers. They can connect you with a clinical hypnotherapist. And then for the cognitive behavioral approaches for the British Menopause Society has a great how to do that type of handout. If you Google British Menopause Society Cognitive Behavioral Therapy or CBT Menopause, it'll pull up how to teach yourself these tricks. Very good. And then weight loss has also been shown to really help with hot flashes in many women, but of course we all know that's easier said than done, right? Next question is for Dr. Newlin. This is regarding sleep. What suggestions do you have to get better sleep throughout the stages of menopause?
Yeah, some of this we've alluded to earlier. So, a lot of what I start with is talking with patients about sleep hygiene, and that comes down to avoiding caffeine in the afternoon, avoiding excess alcohol, keeping your room nice and cool. One of the biggest culprits for affecting our circadian rhythm, meaning our natural inclination towards sleep, are screens. So, it's been shown that the blue light from phones and tablets may counteract our natural impulses to go to sleep. And plus, I don't know about you, but I know doom scrolling or looking through the news right before bed isn't really most conducive to sleep for me. So, really trying to wind down. Some people find meditation to be helpful. And then just talking about what helps for you. So, whatever helps for kind of decreasing that anxiety, increasing that relaxation. And also, if it's menopausal symptoms that are affecting your sleep, if it's coming from hot flashes, if it's coming from night sweats, then really talking with your provider about those symptoms and how they impact your sleep. If you're waking up a lot at night, that's something worth mentioning. And two, if you think that your sleep issues might have a contribution from depression or anxiety, that's something to consider as well. So there are a lot of different treatments and a lot of different options that you can talk with your provider about.
Yeah, and a lot of them have a nice side effect as being sedating, right? So
For sure.
my colleagues talked about some of the antidepressants that have been shown to help with menopause, because not all antidepressants do. It's only selective ones that have been shown to help hot flashes, but there are some that are more sedating, such as paroxetine that comes in generic. And the gabapentin that one of my colleagues mentioned, old-fashioned seizure medication that's used very successfully for hot flashes, can actually help put people to sleep. What are also your thoughts on hormone therapy for Dr. Newland for sleep?
Speaking of kind of treatments to help with sleep, a lot of my patients who are getting progesterone, particularly I use a lot of the micronized prometrium, they take it at night, and that's one of their favorite side effects from it. It's not only are they getting the estrogen benefit from hormone therapy, the progesterone that's uterine protective is also helping them sleep through the night. So I counsel them about it being a side effect, but it's also one of those things that is helpful with menopausal symptoms.
I agree. That's a very popular one in menopause clinics, available in a generic form, micronized progesterone. And if you take it by mouth, it has a nice sedating property for many people. And depends on your metabolism. It could be the lower dose or the higher dose that causes sedation. For some individuals, it's too sedating and they feel drunk with it, in which case we have patients put it in vaginally to get the protection for the uterus. But if you put it in vaginally, typically does not cause as much of that sleep benefit. Perfect. Good. Great questions. Let's see. Next, we're switching gears. So let's talk about sexual health. What are best ways to increase libido? And this is coming to Dr. Zupancic.
So we'll find that the topic of sexual desire in any woman at any age is a very complex topic. So typically, when I have patients coming in to discuss it, we set aside like 45 minutes just to discuss sexual health all on its own. So we'll kind of hit the highlights, if you will, of this. But when we think about sexual desire, we're very complex, complex half of the species, if you will. We ascribe to a model called the biopsychosocial model, which means how we feel about sexual activity depends on how we are feeling, or how our biology, our psychology, and our social upbringing and current situation impacts our lives. So, for example, biologically, what are our hormones like, which is really the biggest one we're going to talk about today? Do we carry diagnoses like high blood pressure or diabetes that can impact our sexual functioning? Do we take specific medications that impact our sexual desire, and do we have injuries? Psychologically, treated anxiety and depression can create low sexual desire. Untreated anxiety and depression can create low sexual desire. So there are some changes to consider there. And then socially as well, things that impact our sexual desire include our relationship. Do we feel safe, supported? Do we communicate well? How are we raised? And for a lot of us, especially as we get older, like, are the dishes put away? Is dinner done? Are the socks off of the floor? So we have a lot of these like subconscious little checklists that a lot of us don't really recognize are there. And so sexual desire as a whole in women is quite complex. Now, if we take apart just the biological aspect of that and focus on it, because we're looking at the hormonal changes of menopause, when we think about the true different chemicals in our body that affect sexual desire, it's estrogen, it's testosterone, which change a lot with that menopausal transition. But then it's also neurotransmitters, which are the chemicals in our brain that kind of help define our mood. So dopamine and norepinephrine can make us feel really sexy, but serotonin, which is common in a lot of antidepressants, can turn that volume down on that feeling. So when we talk about specifically the hormonal aspects of menopausal transition, and even prior to menopause, we'll see that our natural testosterone levels tend to drop a little bit at 35. But then our estrogen and testosterone together really drop around that natural age of menopause, which for most of us is around 51 and a half. So when we talk about adding back sexual desire in women, there's no Viagra. If we give a man a Viagra, it helps with his erection. If I give you a Viagra, that's not going to give you anything for what you want to have sex with. Sexual desire is all about how we perceive our partner in our environment. So we kind of want to change our interpretation of those things, either by adding back hormone replacement therapy, like testosterone transdermally, like through the skin, or estrogen as well, if it's appropriate. Other medications we can consider are things that do change our brain neurochemistry and increase that norepinephrine and dopamine. Medications like Wellbutrin, or medications that turn down serotonin, like Buspar. There are also great medications that have been FDA approved for sexual desire in women prior to menopause. But some of the newer studies that are coming out now show that some of those medications have great application in postmenopausal patients as well, like ADI. So if you have concerns about those things, please bring them up with your provider. The other thing we'll see in menopause is that your body-wide estrogen, as it decreases, your vaginal tissue tends to change a lot, and that creates thinner, drier, less lubricated vaginal tissue, and that can make sex more painful, which then kind of negatively reinforces our want or desire to have sexual activity. And there are a lot of very reasonable ways to go about treating that you can approach with your provider as well.
Very big topic, and thank you. That was a great summary of, and just for those listening in on some of those medications, so that we're using the generic names too for the people to look it up. You mentioned bupropion, you mentioned buspirone, you also mentioned the two that are FDA approved for actually approved for low libido would be flibanserin, which is the ADI that you mentioned, and there's bremelanotide, which is an injection by Lyse. And we're not being paid by any company. We just want patients to be aware of all of their options. Because I use all of these options in my clinic. And so this, you brought up, this was a good intro. So for Dr. Crawford, there's questions about, is there something that could or should be taken to help with vaginal dryness and painful intercourse?
So vaginal dryness and painful intercourse is one of the symptoms that occurs as a result of the low estrogen state in the vagina. Your provider may use the term genitourinary syndrome of menopause to encompass all of the possible low estrogen changes that can occur because it affects the vagina and the urinary tract. So a low estrogen state in the vagina can cause vaginal dryness, burning, urinary urgency, pain with urination, and even more frequent urinary tract infections. So for vaginal dryness with intercourse, specifically, you can start with just the use of vaginal lubricants and moisturizers. The difference is a vaginal lubricant should be used during intercourse, whereas a vaginal moisturizer should be used independent of intercourse and on a regular schedule, depending on the one you choose. Vaginal lubricants can be water-based, oil-based, or silicone-based. It is important that you don't use oil-based lubricants with a condom because it can erode the condom and break it. But silicone or water-based lubricants are fine to use with a condom. Some postmenopausal patients prefer to use oil or silicone-based lubricants because they get better friction control with those. If vaginal lubricants and moisturizers are not controlling your vaginal dryness, then it's time to talk to your women's healthcare professional about prescription treatments that can be used to treat vaginal dryness. The most common is vaginal estrogen, which comes in a vaginal tablet, a cream, or a vaginal ring. We also use DHEA suppositories or cream to treat vaginal estrogen, and that's a prohormone that breaks down into estrogen and testosterone. And then there's an oral medication called Osphena, which can be used for certain patients. You may also talk to your provider about a carbon dioxide intravaginal laser treatment that can be used to treat vaginal dryness and menopause. The data for this is a little bit limited and it's not yet FDA approved for this indication, but for certain patients, we do recommend this.
Perfect. And looks like I have a question that's being sent my way. It's about, please speak to hormone replacement therapy. How do you know if you need it? What are the pros and cons? Similarly big topic, like talking about libido. So I'll try to do it justice in a few minutes. First of all, the terms hormone replacement therapy versus hormone therapy. So hormone replacement therapy implies that we're replacing something. So if you are an individual who in your 20s or 30s went through an early menopause, that's what hormone replacement therapy refers to. And that all society guidelines agree. Unless you have an estrogen sensitive cancer like breast cancer, there are very few reasons why we wouldn't give back the estrogen, because we know the risks of multiple things are worsened when you lose estrogen at a young age. Increased chance of dying, increased cardiovascular disease, increased neurological conditions. So that's hormone replacement therapy versus hormone therapy. The term is different. That's for, I went through natural age of menopause, which in the US is considered 52. And now I'm having symptoms and I'm trying to decide whether I want to prolong my hormone exposure. It truly is a therapy. It's not a replacement. In that situation, it's a different measure of pros and cons, and this is why it's a very individualized decision. In general, those individuals who are within 10 years of menopause are going to have the best pros versus cons, versus if you're in your mid to later 60s, more than a decade out from menopause, in your 70s, we're probably going to talk to you about considering non-hormonal treatment options. Most of the guidelines would recommend doing hormone therapy for symptoms, the quality of life symptoms, the vaginal dryness, the sleep concerns, the mood concerns, the hot flashes. Guidelines are split on whether you should use it for preventing disease. So most guidelines say don't use hormone therapy to prevent any kind of chronic medical condition. The one exception is the Menopause Society does leave the door open that if you have low bone density, bad osteopenia, osteoporosis, and the other medication treatments are not appropriate or acceptable to you, then the Menopause Society does say that in that situation, as long as the patient understands the pros and cons of long-term hormone therapy use, it's okay to use. So for all intents and purposes, usually used in the 40s and 50s, for 5 years or less for most individuals, but not necessarily. It really depends on the risks and the benefits, because there's a lot of benefits and there's some risks. So there's reduction, in addition to the symptom improvement and improved bone density, there's a reduction in diabetes, there's a reduction, improvement in insulin resistance. There's some trends towards increased colon cancer prevention, and study after study shows that individuals on hormone replacement during the time that they're on the hormone therapy seem to die less often than non-users. That mortality, we call that mortality benefit, doesn't seem to persist once you come off. However, there's some cons to consider. We know that after 5 years of use, that there can be a small bump in the breast cancer risk. That is a small bump. It's in what we call the rare category, which means it's a similar level of risk as having a few glasses of wine with dinner per week. However, nonetheless, it's important to know the pros and cons, because if you have a very high risk for a breast cancer in your family, that might make you nervous. But that risk does start at 5 years and beyond. And then the two main things that we worry about is the cancer risk I mentioned with the breast cancer, and then the blood clotting risk. So the blood clots can be in the arteries that go to our heart and to the brain, or to the legs. In general, when you are younger, in your 40s and 50s, going on hormone therapy, In fact, if you're only on estrogen, there's been studies that show more benefit for the estrogen. So we don't worry quite as much as the heart or stroke risk for younger individuals, but the blood clotting risk, again, is in the rare category of risk. So that means if I write 1,000 prescriptions and refill them for 5 years, I'm going to bump up likely one woman's risk for a blood clot. So something to weigh in your own personal pros and cons. For some individuals, they're feeling terrible. They've got a lot of bone density concerns, other symptoms for them. Those rare risks are totally worth it. And other individuals, they don't really have many symptoms and they don't want to take on more risk than they need. And then there's always conversation about the uterine cancer risk. So it turns out if you're taking appropriate, so the uterine cancer risk is only an issue for individuals with a uterus. The nice thing is if you've had a hysterectomy and you need only estrogen, we know the risks to the breast is minimal to none. In fact, with certain formulations, they've looked at, they've followed these individuals for 20 years, they actually not only had a lesser chance of dying with breast cancer, but like not only had a lesser chance of being diagnosed with breast cancer, but a lesser chance of being dying with it. But that is for individuals who are taking estrogen alone. So if you need to add the progestin, that's where the progestin takes away from the cardiovascular benefits and contributes to the breast risk. But you absolutely need to take some sort of progesterone or progestin if you have a uterus, otherwise your risk of uterine cancer is increased. If you're taking it appropriately dosed, appropriately managed, then your risk of uterine cancer with estrogen, progestin, hormone therapy is actually less than not taking hormones. But again, this is where we worry about pellets and other things where people can get really high doses. And if you're not being properly managed, and the one other thing I'll call out here is if you're doing custom compounded hormone therapy, you do have to be careful that when people do a cream, sorry if it's loud, it's the AC is going on and off. But if you do a compounded cream from someone, a lot of them have estrogen and testosterone in it, and they put the progesterone into that same cream. If you have a uterus, we know that estrogen is readily absorbed, so it's going to your uterus, but that progesterone is not. And we have published a series of patients who came in and their only risk factor for uterine cancer was the fact that they were on these custom compounded therapies. So you really, if you're putting estrogen on your skin, except for the certain vaginal formulations, and if you're putting them in a systemic way, compounded, you need to make sure you're doing adequate progesterone. And then the testosterone, there's much less data on long-term safety of testosterone, but multiple medical societies feel that it is safe to try for sexual health after menopause when you're no longer worried about getting pregnant. But the studies only go about 2 years for safety. And they, excluded people who are high risk for breast cancer, for heart disease. But as long as you're using the testosterone in reasonable reproductive doses and not, again, these mega doses that we see sometimes coming in, then it's considered safe to trial. And I want to not hog the conversation, so let's keep going. For hair, what can be done for thinning hair due to menopause, Dr. Zupancic?
So I think it's important to note that we all lose a certain amount of hair every day. I was reading an article last night that said we lose 50 to 100 hairs per day on average, and that's even before we go through menopause. And at any point in time, I think around 85% of our hair is growing and 5 to 15% is shedding or getting ready to shed, with that cycle lasting about 7 years. So we're always growing and shedding, and once in a while we go through a larger shedding event than others. That being said, we do know that estrogen affects hair follicles, but we don't know how. There's been a lot of investigative research in how estrogen directly impacts hair follicle growth, but we're not exactly sure the mechanism by how that works. But we do know that estrogen itself kind of promotes hair growth. And this sounds odd, but bear with me for a second. Testosterone can increase hair loss. Throughout our lives, we typically have a very overall reasonable presence of testosterone in our bodies. And when we have estrogen involved as well, it balances out the effect that testosterone has on our hair follicles. When we go through menopause and that estrogen drops, whatever testosterone we have left is more or less left unopposed to impact our hairline. And that can lead to a lot more hair loss, or what we call telogen phase hair loss. Not all of this can be perfectly improved. Hormone replacement therapy or hormonal therapy has not been shown to improve your hairline. But if this is something that is bothersome to you, there are options for medication that you can approach in dermatology referrals that we can set you up with as well. One of the first line therapies is minoxidil, also known as Rogaine, which you can buy over the counter. They recommend applying it to the scalp once a day and washing your face very well with it as well, because it can grow hair in other places that it touches. Other medications that you can take orally to decrease testosterone further can also improve your rate of hair loss as well. But all of these options, you're not going to see true progress with them for about 3 to 6 months. There are I have a lot of patients that come into my office asking about vitamins and different vitamins to take to help with hair growth. And if you look at a lot of dermatological research, not many vitamins have been shown to help with hair growth. I have a lot of patients coming and talking about zinc, B12, folic acid, biotin, and not many of them have been shown to be associated with improved hair growth. But some studies have shown that if you're anemic, increasing your iron can help with hair growth. As well as taking vitamin C to improve that iron absorption, making sure you have enough protein in your diet and some carbs. Vitamin D deficiency can also be implicated in hair loss. And if you live in Northeastern Ohio, like the rest of us up here, the majority of us are vitamin D deficient and should be replacing that every day anyways. So, we treat these things symptomatically. There's not a perfect solution for them. There are also hair loss clinics in the area or dermatologists that specialize in this topic as well.
Perfect. Here's another excellent question coming to Dr. Crawford. How do you know what is a menopause symptom versus a health concern?
This is a really important question. Don't try to make this determination yourself. If you are experiencing a symptom that you think is due to menopause, it's bothering you or interfering with your quality of life, you definitely need to see your menopause healthcare professional to discuss this, to see if further workup is recommended. There are a lot of healthcare problems or health problems that can mimic symptoms of menopause, including, for example, thyroid disease, cardiovascular disease, mood disorders such as depression, anxiety, and even cancer. Your menopause professional may recommend that you start hormone therapy or a non-hormonal therapy if you're experiencing hot flashes or night sweats. It is important that you follow up if your symptoms don't improve for further workup.
Right. And here's a philosophical question, a great question. I always tell my husband, I've gone through 3 pregnancies, a miscarriage, menopause, all the stuff, and he gets to go through everything nice and stable. So if somebody asks, why is menopause so hard on our bodies?
Well, I think the thing to note is that it's a huge chemical change. So your body is accustomed to a certain level of estrogen. You've been cycling since puberty, and then all of a sudden that estrogen is going away. And I think, too, it's worth noting that menopause happens to fall in a time when we're still very busy in our lives. Like a lot of people have aging parents, their kids are getting older. We're expected to manage the whole household. There's not really an opportunity to be like, "Whoa, I got to take off. It's my menopause." So we're trying to go, go, go. And 2, as a society, we traditionally haven't carved out a lot of time and space to talk about menopause. So I think a lot of women are just expecting to have to push through these symptoms and to suffer in silence. So I'm happy that we're devoting more time and space to talking through and normalize talking through these symptoms, because they can be really life impacting. And it can be very hard on our bodies, and to really let people know that there are treatments and things that we can do to help alleviate these symptoms.
Yeah, it's interesting. I was on a meeting this morning in the International Menopause Society, which brings people talking about menopause from all over the world. And one colleague said in their country, they weren't even allowed to lecture or comment about menopause until recently. So I'm so glad we're talking about all this, because you hit the nail on the head. It really does impact us in different ways. So this is coming to Dr. Zupancic. What lifestyle changes are important to make during menopausal years for good health?
So what we'll see in women is right around that menopausal transition, there are two big things that can really change the overall outcome and the quality of our life. One is we lose the most bone mineral density that we're ever going to lose in our life within the first several years after our hormones stop naturally cycling. The other thing that we'll see is estrogen up until this point in our life has been very cardioprotective, which means it's keeping our cholesterol levels lower. We're less likely to have blood clots or strokes, things along those lines. And then once that estrogen level drops, that cardiovascular risk goes up again. And so the lifestyle changes that we think about to improve our longevity as we go through menopause really truly focus on our bone health and on our cardiovascular health. So when I think about bone health, I think about calcium and vitamin D repletion. You know, we do recommend 1,200 milligrams of calcium daily and vitamin D 800 international units daily to continue to improve and stabilize that bone loss as we get older. And then weight-bearing exercises have been shown to really improve the retention of bone mineral density as we age. And as Dr. Bator had said earlier, you know, if we have concerns about lower bone mineral density, even at the younger age of like 51 or 52, as we go through this natural transition, estrogen replacement or estrogen therapy can help stabilize that as well. So for bone health, I would always recommend calcium and vitamin D supplementation and weight-bearing exercises. As far as protecting your cardiovascular health, it's a lot of what we've talked about already, diet and exercise. So keeping your cholesterol low, following that Mediterranean diet, and then limiting your alcohol risk as well, as alcohol over time has been shown to increase osteoporosis risk and dementia risk as well. And there used to be a strong thought that, you know, one alcoholic beverage per woman per day was considered the lower or the upper limit of safety. But even recently, we're seeing that no alcohol is even better. So there's not really a perfect margin of safety with alcohol use either. But certainly to keep that cardiovascular health protected, exercise and diet are always going to be the number one things.
Perfect. And we have so many great questions. There's no way we're going to get through all of them. So I'm going to skip around a little bit because we're covering some of them already as we talk. So this one came to me. Are there any natural remedies to alleviate menopause symptoms? Remember, we were talking about how the Menopause Society spends a lot of time, money, and effort to really look at the science and what really works and what doesn't. So unfortunately, a lot of the supplements have not been shown to benefit more than placebo, even though it's a multi-billion-dollar industry. Now, that being said, people may take supplements for other reasons. So for example, chasteberry or things like that, that people might take for PMS or other symptoms that might help them, but in the context of menopause, hasn't been shown to help. So in general, if somebody is on something and it's really helping them and it's not harming them, I'm not going to tell them to come off, but I don't also want to recommend things that don't have proof. But the cognitive behavioral approaches, the hypnotherapy, weight loss, those are natural remedies that have been shown to help. Magnesium, we know, can help with body aches and sleep, so that's something I recommend. A lot of our sleep doctors are okay with people taking melatonin, 5 milligrams or less. So sometimes symptom specific, like Dr. Zupancic recommended about for the hair. So I really base it more on symptoms, but in menopause in general, not unfortunately too many scientifically proven supplements. So I'm going to jump to Dr. Crawford's question. What supplements should menopausal women be taking?
So yes, supplements you definitely have to be careful with because over supplementing can have negative health consequences. Certainly there will never be an adequate substitute or supplement for a healthy, well-balanced diet that's rich in fruits and vegetables. Menopausal women, peri and postmenopausal women do need between 1,000 and 1,200 milligrams of calcium daily. Ideally, this should come from your diet as much as you can extract from your diet and then supplement the gap. So some dietary sources include dairy products, beans and lentils, almonds, and leafy green vegetables. And then vitamin D supplementation is also very important for bone health. For most people, between 800 and 2,000 international units per day is considered safe.
Perfect. And so that we end up covering some of the other questions. So I think in our last few minutes here, I'm going to jump to question for Dr. Newland. What can help with fatigue and low energy? Will I ever have the same energy level as before menopause?
So definitely we've talked about sleep concerns. So that's one of the biggest contributors to fatigue. So all the sleep recommendations we talked about before can certainly still hold true here. Regular exercise has been shown to counteract fatigue and low energy. If I were speaking with someone in my office, I'd really want to make sure that depression wasn't contributing to kind of that ongoing fatigue and low energy. And then I think when someone asks if they'll ever have the same level of energy as they did before, I would say that depends. So we're all aging, and not to be flippant, but I don't have the same energy as my 4.5-year-old. So I think it's a matter of, I want to get you feeling good. I may not be able, I can't get myself back where I was when I was 20. So I think I want to manage your symptoms. I want to help, but definitely like diet, exercise, kind of talking about all of those things, getting good sleep and feeling good in a mental health realm too.
And one of the topics we didn't touch on, this is going to come to Dr. Zupancic. Does menopause cause joint pain, and what can I do about it?
Yeah, menopause is definitely associated with joint pain. They say about 50% of menopausal women do experience joint pain. And even when I have patients that come in being treated for breast cancer with medications that block estrogen, one of the biggest side effects with those is joint pain. And this is, again, one of those things that we don't know the exact mechanism of action as to why estrogen levels affect joint pain, but we do know that estrogen plays a role in both cartilage health, which is that kind of like softer tissue where the joints come together, and then synovium health, which is the oily fluid that kind of acts like the WD-40 between our joints. And then as that estrogen level drops, we lose kind of the integrity of those joints, and they tend to rub against each other more, creating more joint pain. There isn't a specific treatment for what we call menopausal arthralgia or menopausal joint pain. Often we do discuss things like supportive care, so things that you've probably done over the course of your life already: pillows, cushions, heating pads, warm showers, baths, stretching, anything to keep your joints kind of moving well and keep from getting stiff. There are some supplements that can help. So glucosamine and chondroitin are often recommended. Fish oil, turmeric, which has some anti-inflammatory properties, and vitamin D as well. Vitamin D can also be linked to joint pain. We treat mostly with NSAIDs or things that lower inflammation, like ibuprofen or Tylenol. If that's not quite doing it and you have one joint that's bothering you a lot more than any other joint, we could always get you set up with a subspecialist in orthopedics to evaluate that for you. Hormone replacement therapy, or hormone therapy, I should say, isn't indicated for joint pain. It's indicated mostly for hot flashes, night sweats, and bone mineral density protection. But when we do have women taking it for those indications, a relief in that joint pain is often accompanying that medication as well.
Yeah, it's really interesting. For a recent talk, I did an updated review of the evidence, and there was more than 17 studies showing definitively how joints can be impacted this phase of life. In fact, 70% of people, I think was what they were quoting, experienced symptoms. But guess how many scientific studies on treating it with hormone therapy or other options? 0. So we know it happens, but we just need to study it, like how to help it, right? And then this is the last question of the evening, which looks like it was headed towards me anyways. It was about the formulations with the hormone therapy. Like, what's the best option? And this is where it becomes very individualized. One of our favorite options during the menopause transition, Dr. Crawford alluded to, is where we do an IUD that provides the progestin through the uterus, minimizing systemic exposure, controlling the bleeding, and then you can use any low dose of hormone that you want to help with symptoms. So that's a popular choice during perimenopause, or we end up using low dose birth control pills to better manage symptoms. Once you're in menopause, you can use oftentimes much lower doses. Patches can help with minimizing clotting risks, or not just necessarily patches, but anything where you're going through the skin. There's other gels and vaginal formulations that can do that. But just a reminder that if you have a uterus, you need to take a progesterone to prevent uterine cancer. And this is where you really would need a one-on-one visit to have that conversation about what's the best option for you. So this was our last question of the evening. So thank you so much, all of you, for your interest. And this is the conclusion of our Ask the Experts event. Before the end of the week, you're going to receive an email with menopause and women's health related resources, details on how you can make an appointment, and a link to the recording of this event so you can review it again. Thank you so much and have a great night. And thank you to my colleagues.